but my bit's first anyway, so not the most important meaty bit of the presentation. So welcome to the final show and tell now for this phase of the project for the Primary Care Pathfinder discovery. Jem, if you're okay to start recording, just so I can see that you have, thank you. And just to let everyone know that we are recording the session. Okay, so I'm going to get straight into it. So what are we going to cover today? So we've got an introduction, I'll take you through that. Adam is going to give you a bit of a lowdown on what the story is so far, and then we're going to deep dive into 3 of those areas within that story. So health records access and demand for GP services, and also digital interventions. I'll then cover off what's next, so what happens immediately after this show and tell, and then any questions, if I could ask that you save those to the end. We've got a lot to cover today and quite a tight timeline, which we've been working on today quite a lot. So if I could ask that you keep all the questions to the end, that would be much appreciated. But feel free to use the chat box and kind of chat for yourselves, ask any questions in there. That's absolutely fine and is actually encouraged. Okay, so just quickly touching on this slide then. So I won't go into detail about the problem statement, but it is essentially what we aim to investigate within the 12-week discovery. Hopefully this is nothing new to this audience. So like I say, I won't go into detail, but if anyone does want to reach out with any questions to me directly, that's absolutely fine. But what is important to note on this slide, that the team will be talking through a couple of insights and findings today, which we've picked out specifically to speak to this audience about. And I know that you're all aware on the call, but primary care is an absolutely huge, vast landscape, and we're a team of 4 with 12 weeks. So if that sounds like a lot of work, it's because it is. And there's definitely going to be some further work that's needed. The project itself, like the note says at the bottom, there is a holistic view of the issues faced in primary care for patient-facing services, and we'll recommend where to focus next in detail in the report. At the end of the discovery insights will obviously, like I say, need to be explored further. And again, in the report, we'll kind of pick out those recommendations where we kind of see that the focus should be first. So that's just to set the context of what we're going to be talking to you about today. And I will, without further ado, pass straight over to Adam to get into the meat of the presentation.
Hiya, Jen's going to pop in and see her now.
Oh, if I could just ask people
to
remain on. I think I can actually override and do that. There we go. Apologies for whoever that was. Adam, over to you.
Thanks, Anna. Hi, everybody. Welcome. It's great to see so many of you here again. So I'm going to give a whistle-stop tour at a very high level of what we've learned. All of these topics are clearly interrelated, but I've put them into bands across the screen to show the things that are clearly connected to each other. So the first thing we would ever do in a project of this nature, and certainly with the problem statement that we have, is try to understand the wider landscape in which digital services in primary care sit. And so we've gone back and we've looked at the parliamentary review that took place in 2017. We've looked at the plans for health and care that the Welsh Government put out in response to that in 2018. And we've looked at the primary care model for Wales that was released in response to a Healthier Wales that came out in 2019. And what is clear from looking at this landscape is that the health and care system faces multiple challenges, and these are well documented. What's interesting is that they are challenges that are faced by most developing countries, in actual fact. And why that's interesting is that means there's an international body of evidence of how those challenges can be tackled. So that's number one. So number two, these challenges are quite naturally forcing changes to models of health and care. So specifically in primary care, it has led to the release of the primary care model for Wales, which talks about how we can make a cohesive set of changes to primary care that will help to tackle some of the challenges we face. And the challenges are well understood. Broadly, they're along the terms of that demand is outstripping capacity, and there are challenges in increasing capacity to meet that demand. And that's at a very, very broad, high level. So we've seen there are challenges, there are changes to models that are taking place in response to those. What we've seen from our primary research in all the strands that we've undertaken on this project is that there is already changes taking place to align with the new model of primary care in Wales. We've seen that in our conversations with citizens, in our conversations with practice staff, and in our conversations with a wide range of stakeholders at various levels in the system. And that's a good news story, I think, is that in some ways what is laid out in a primary care model for Wales has a gap between the theory and the practical application on the ground. But what we're seeing is that on the ground, those changes are starting to occur. So now I'm going to look at the next thread. So looking at number 4, access to GP health records is a contentious issue. One of the stakeholders I spoke to described it as a vexed issue, which is a term I think that sums it up beautifully. And what that means is that there are problems with sharing GP records more widely, and there are clearly benefits in doing that. And you can break that out into 2 separate areas. So number 5, there's the concept of giving a more ready access to citizens' own health records, which we are going to dive into in more detail during the presentation today. And then there's also the idea of information sharing much more broadly between professionals who are engaged in the care of an individual. And it's pretty clear that that is going to be a critical challenge for the future model of primary care, which relies on distributing demand of primary care more evenly across a wider range of healthcare professionals, not just within the contracted providers in primary care, but out into community care, across allied health professionals, into social care, and then even drawing even further across organisational boundaries into things like local authorities and the voluntary sector. So at which point that information sharing is almost an existential threat. We need to get it right for that to work seamlessly, which is what future models of care are aiming for. But as I said, the number 5 point is the one we'll dive into deeper today, looking at the records access for citizens and the benefits and challenges that are presented by that idea. So then looking at the 3rd row down, number 7. So this is not news to anyone on the call, I hope. The access to GP services remains the main challenge for citizens. I know that everyone hopes that when you do a discovery, you'll go out and you'll find out that the commonly held views are incorrect, and actually you find out something that nobody knew about. But the fact is this remains the primary problem from a citizen's perspective. And almost like the flip side of the same coin, managing the demand of that access in practices is the challenge that practices face. That's the thing that all of them are wrestling with the most and experimenting with different ways to handle this increasing demand that's happened. And of course, this has become particularly exacerbated during the pandemic, when things like limiting face-to-face appointments and etc. became more of an issue. We're going to dive into both of those topics today as well. What's interesting is that practices are changing how citizens access services, and we've seen numbers of different ways that they are experimenting with this. And we've actually witnessed a huge range of what I would call access models. That is the range of channels through which citizens can try and get an appointment or indeed consult with a clinician. There's a huge range on offer across the practices we spoke to. From the citizen's perspective, how they want to access GP services is not uniform. And it's not even uniform by particular cohorts, although that can influence it. It has a lot more to do with the task that they are trying to do at a particular time and the context of that particular task, including whether they're in pain, the emotional state they're in, how urgent it feels, etc. And that is likely to have the largest effect on how they want to try and access services in GP practices. And looking across to number 11, I mentioned that there's this proliferation of different access models between practices that we've observed during our research. And there's some evidence leading to a sort of a hypothesis or a concern that the huge variability may be leading to inequities in health outcomes for residents, depending on which practice it is that they go to. And that's something that could do with further examination. And finally, this is a project about digital services. And so, of course, we want to talk to you about the use of digital tools that we've observed. We've looked at how they're being used. We've looked at opportunities for new ones to be introduced. And we looked at how they would fit into the strategic direction of primary care in Wales. And what's clear is that you can't say that digital deployment has been an unqualified success in Wales during the pandemic. And some would take that as a negative. And in fact, we have seen services being turned off or limited to a great deal. However, in every case, the reasons for the services not delivering the outcomes that we would hope that they would have been very clear. And so in actual fact, it's a very positive thing, is that we can learn from those lessons and take them forwards into work into the future. So that's the overview, I think, of what we've learned. But as I said, we're going to dive into these areas that indicated with the yellow dots in more focus now as we move ahead in this presentation. So next slide, please, Hannah.
Great, thanks, Adam. So just jumping into our first deep dive section then, all around health records access. And I think straight back over to you, Adam, if that's okay.
Thanks very much, Hannah. So for those of you who don't know, I'm sure you all do, there are two levels of access, crudely speaking, and that is the summary level, which basically shows a list of problems that a citizen has, medications they're on, allergies they have, vaccinations or immunizations they've had, etc. Does not include any free text or any letters attached to it. On the flip side, there's the full text record, which has everything, all the letters, all the free text comments, etc. Citizen access to a summary level record has actually been technically feasible for some time via tools such as My Health Online. However, practices have control and choice over whether or not they turn it on. And in fact, that choice is down to an individual citizen. And I think it's even down to individual pieces of information that can be turned on or off. And I think only 3 of the practices we spoke to have turned it on, which is perhaps illustrative of what it's like across Wales. And Heather will talk about that in more detail. It's a topical topic because in England, the NHS has committed to introducing a full rollout of full text records on a prospective basis, which means from a certain point in time, all records from that point forwards will be available to the citizen directly via electronic apps. And there are many implications of this. It is their intention as well, or it's on their agenda to also roll out retrospective full text access at a later date. And now I'm going to pass across to Heather, who's going to tell you about what we heard about this topic when we spoke to practice staff.
Oh, Adam, I think this was you.
I'm going to carry on.
Yes,
so I'm going to have at least one slip up every time. So I want to summarise the main challenges of sharing records access with citizens as we have seen them in the research we've done. So clearly there's a risk to the GP. They are the data controller, and any data breaches are their responsibility, which can bring hefty penalties in terms of fines under GDPR. Along with that, full text access brings an admin burden with it, because GPs are responsible for going through all the text and redacting in any information that can't be shared legally with a patient, typically things connected to a third party. Alongside that, there are ethical or conceptual quandaries around deciding to whom it's appropriate to give access and under what circumstances. And there are clearly some groups for whom having that sort of access could be potentially harmful. So there's an ethical quandary there to unpick. Alongside that, there is this fear that there would be an increase in demand onto practices by releasing more wide access to health records, because this could bring with it a range of inbound contact from citizens who want to understand something in their record that doesn't make sense, or to query a result where it looks like it's slightly out of range, even though it was deemed by the GP at the time to be completely safe. As we've alluded to earlier on in point 3, there is the potential for individuals to access information in a full text record that can cause them significant distress, things that perhaps they weren't aware of before that were emotionally worrying for them. So that's another consideration and something that could also add to the admin burden and the ethical quandary involved. And finally, one that's talked about quite extensively when having these conversations is the risk that those people who are unfortunate enough to be in coercive or bullying relationships are at risk of coming to greater harm if they are forced to disclose their health records to a third party, particularly if they then find out that the nature of their relationship has been disclosed to a clinician in the past. Next slide, please. There are many benefits though, and starting with the first one, which is sort of a bit difficult to pin down, but sort of feels instinctively right, which is that this is information about an individual that should be available to them on principle because it is about them. And this is a widely held view amongst practice staff, amongst stakeholders, etc. Interestingly, it's met with mild disinterest from citizens we spoke to, but that may be because they haven't thought through the implications of what that information might mean to them or what they could do with it. It could theoretically support citizens to make a much more proactive role in their own health and care, and this is particularly true for those who are wrestling with the combinations of complex health conditions, where being able to have direct access to their records, to understand what diagnoses say, to understand what recommendations have been written down, to understand what the latest test results say or the medications and how they're varying, could help them manage their health conditions on an ongoing day-to-day basis if they had ready digital access to it. It opens up the possibility too of allowing a citizen to choose with whom they share information. So they could choose to share information with somebody who is caring for them, who doesn't currently have access to it due to other data limitations in the system, which could allow them to have more efficient or more effective care given. Theoretically, this could reduce demand on GP practices. We haven't seen evidence of this in our own research, but you can see that individuals being able to check for themselves routine things, such as whether they've had a vaccination or what their latest test results say, could result in less inbound contact into a surgery. And finally, it almost gives us the opportunity to crowdsource the data quality of records by allowing individuals to spot errors in their own records and raise them and get them corrected. And this could become increasingly important as stratified approaches to healthcare are carried out, and where stratification is done on the basis of codes in GPs' records. So it's important that those codes are actually accurate if health and care decisions are going to be made on the basis of them. And at this point, I think I am passing over to Heather.
Thank you very much. If we move on to the next screen. So as Adam said, we spoke to 3 practices who have switched on that record sharing. Now worth noting that we did speak to 23 practices in total, and 3 of them had taken part in record sharing. Also worth noting that none of the people that we spoke to were involved in that decision making to switch on record sharing. So it is purely about how they perceive the experience as being and how detailed that is. So for practice 1, why did they switch it on? Well, there was this kind of view that the phone lines are clogged up with people wanting results. If there's the option there and they can access it another way, then why not do that? When we kind of delved into what do they think patients can see when they look at those records, and they kind of mentioned, well, they can see medication and test results, but they weren't entirely sure what else they could see. When it came to kind of potential awareness of record sharing, they did say that there was no hard sell, there was no big comms. It was switched on for all patients, but patient awareness of it is pretty minimal. And it switched on for everyone, but they didn't really see any kind of additional call volumes coming through, just some calls coming in from people that maybe had saw it and wanted to kind of question or talk through some of the things on it. So really minimal feedback from patients as well. So for them, they've not experienced any kind of significant downside, but they kind of caveated that with that they're not entirely sure the number of patients that are accessing it, again, because that kind of awareness in the first place is pretty minimal. If we move on to the next slide. So the second practice. So again, this was individuals' experience. They had mentioned that they weren't involved in the pilot that's happened a few years ago, but they did think that the practice currently offers a record access. We checked that subsequently, they do have that functionality switched on. Now, as the individual was kind of unsure about it being switched on or kind of what was shared, because they could only really talk about their personal experience, so they were limited in what they could tell us. But although they were limited in what they could tell us, when we spoke to them about kind of demand in the practice and the reasons for people contacting the practice, record sharing questions didn't feature in that. Now, we kind of expect that if record sharing was driving high levels of contact, that would come out in that conversation, but that is an assumption going forward at this stage for that. If we move on to the next slide, and so this is the third practice that I spoke to. So as far as this individual was aware, patients can see their health record in its entirety. They can't see their whole record. It's set to the lowest level, and this was something that was switched on pre-pandemic. As far as they were aware, the push for this didn't come as a result from patients, but it was kind of encouraged by IT to open that up. And the kind of thought behind that was, if there's lots of people wanting to see blood test results, when there's no reason if there's another way they can do it, that they shouldn't have access to do it, and that it could potentially reduce some calls. But they did stress that they're not overloaded with that kind of request at the moment, so they're not finding that kind of test result calls are overwhelming. It just gave people another access in to see that. And again, they haven't seen any increase in inquiries or questions about the records or what they mean for them. Hannah, hand over back to you.
Perfect, thanks Heather. So on to the next deep dive then, and this is kind of a two-parter, I suppose. This is all about access and demand. So I think I'm straight over to, is this Heather, you again, or Leonie?
It's me first.
Oh, 1 out of 3 and got them both wrong. Go for Adam.
One strike. So as we've said, clearly a key challenge, and Leonie will talk about how this was evident from our citizen research. I just wanted to say that when we spoke to senior stakeholders across policy, strategy and local health board roles, this was the #1 challenge that they said, this is where digital tools should play a mitigating role. And please, can we find out how to make them work better than they have done so far? So it was reinforced how important it was. But I'll pass over to Leonie now.
Thanks, Adam. Yeah, so the headline finding from the quantitative research that the Digital Services for Patients and Public, that's the DSPP, commissioned at the end of last year. Headline finding from that had 406 respondents in Wales, and 52% of them experienced issues accessing health services, whether online or offline, they said. 108 of those responses said that the main issue was that it was hard to get an appointment. 76 of them answered, can't get through to surgery on phone. And I actually saw this after doing research with a qualitative sample, which is much smaller. But when you look at findings from across the piece, different audiences captured in different ways, and you get consistent findings, it gives you a level of confidence, obviously. So we're pretty confident this is a problem. A few people made the point that it was hard to get test results, or that the online contact service wasn't available. And again, very small number who were using assistive technology. So that's screen readers, voice to text technology such as Dragon, naturally speaking. They were finding that there were barriers to those to that assistive technology. It's to do with the way that the websites are built, or the tools are built. So we don't know from quant research what exactly those barriers are, but that's why we do the qualitative work. So next slide, please. So why was it difficult to get through on the to surgery? Partly surgery rules, so just the conventions about calling up at specific times. So people who hadn't been in touch for a while would call up at any time of day and be told to call back in the morning. So that presented them with some kind of delay. Then this quote, even pre-COVID, it's having to phone up at 8 AM, still getting told I'm 34th in the queue. So 33 have phoned in 3 seconds before I called, said one man who was just incredulous that the phone lines could be quite so busy, and mystified as to how all these people have managed to get in before him. So they found it difficult for a number of reasons, but it's largely to do with just phone congestion. people saying that they held the line 50 minutes before they actually went through to any kind of recorded message or a person. Others mentioning that they counted the number of redials made on their mobile phones. One said she'd seen 97 and a neighbour had 140 something. So just anecdotal, kind of very specific redial numbers. The other thing that made it difficult for people was just not being sure how these digital channels worked. So where digital tools to request a callback or some kind of consultation with the surgery were involved, there hadn't been the kind of communication that patients were expecting to know and to understand about how the whole thing works. So this idea of a blended model is absolutely right, but it's going to kind of bump up against the same friction if people don't know how it's going to actually be integrated with telephone channels and people turning up in person. So the uncertainty was reflected in the kind of comments that people made about not knowing if they would be disadvantaged by doing something through an online channel as opposed to turning up in person. Some people live close enough to the surgery to visit in person, so where they had perhaps first tried the phone, be directed to a digital booking tool, and then hadn't got what they wanted, they would just turn up in person and use their physical presence to circumvent those systems and to persuade receptionists. The other thing that people perceived as making it difficult was the screening process that the receptionists go through. So it's wide understanding about why that process was a good idea, is a good idea, and citizens buy the idea that the most in need of attention should receive it, they should be in line. But just not understanding how the whole thing was working, or finding that they got on better by turning up in person, for example, was leading people to believe that the process wasn't fair to start with, and that it wasn't working. There was some objection to receptionists asking questions about somebody's reasons for wanting to see a doctor, which was seen as intrusive by some. Others just felt that they were being triaged. In fact, they didn't call these questions screening, they called it triage. They saw it as a kind of pre-triage by somebody who wasn't medically qualified. Over to you, Adam, for the next slide.
Thanks, Leonie. So this is not a new problem, as you know. What is new, or what is certainly constantly evolving, are approaches to how this can be tackled. We're now sitting on a some 20-year body of experience from other sectors that have been working ever since the internet era dawned to use combinations of different contact channels to better manage demand into organisations. And there is some emerging evidence now in primary care as well that this can work. So there's a very recent study I quote here at the bottom that came out in March 2022. It looked at 7.5 million requests into GP practices. I think it was over 140 GP practices. And it concluded that the use of an online consultation tool can be effective in managing demand and prioritising care based on need. So it's plausible that it can be done. I think it just needs care, and we're going to talk more about that later on in this presentation. So if we move on to the next slide, please.
Okay, great. Now we're going to tackle the other side of the same coin, demand. So I'll just flick on to the next screen now.
Thanks, Hannah. So as I said, these are two sides of the same coin, obviously. And we know GP practices are struggling with the demand from their side, backstage, so to speak. And to be clear, by demand, we mean any external request to do something that comes into a practice, and any subsequent work they have to do in order to fulfill and carry out that request. Next slide, please. And over to you, Heather.
Yeah, thank you. So yeah, when we spoke to practices, it came out kind of very clearly that practices acknowledged that for their patients, like contacting the practice is the kind of biggest hurdle, and for practices, in order to manage that demand, many practices are still operating that kind of call within certain times, depending on the reason for your call. So phone between these times for an appointment, phone between these times for test results, so they can manage that throughout the day. Now, during most practices, obviously at the point of the pandemic hit, they stopped using online bookings and moved to this kind of telephone first. And this was like about kind of triage and like who can be whose conditions or can be managed by telephone and who actually needs to be brought into the surgery. And let's make sure that they're not displaying COVID symptoms before we do that. Now, there was some practices that were already making that move pre-pandemic, but for the majority of it, they moved to that with the arrival of the pandemic. Some are now slowly moving back to that kind of opening up online bookings for kind of like routine and campaign appointments, such as kind of like asthma reviews, smears, flu vaccinations, that kind of thing. But there were issues raised around about the online booking and concerns about that as well, and that people don't always book the right slot with the right clinician, or they're booking in for treatments that aren't relevant for them because they're viewing it as seen as getting their foot in the door as such, and getting access to speak to someone. With that kind of telephone first kind of move, most practices are operating this kind of same day consultation. So again, this is about trying to manage demand, but this creates its own set of problems in that obviously there's limited capacity. The practices told us that emergency calls are serviced by an on-call doctor during the day, but with that kind of idea of people get a call back on that day or the next day, it means there's limited scope for kind of booking advanced appointments, and it kind of creates that bottleneck again. And even when practices are kind of operating out with that call at this time, so it's like call any point to arrange an appointment, it's still not creating an even spread of calls. It's still bottlenecking is still occurring. It just moves the time that it occurs at. So it's maybe not happening at 8 o'clock, it's maybe happening at 10 o'clock. So it's not evening things out for practices. And also, as the kind of I think Adam touched on earlier about practices are using digital channels to kind of open up access. So where they're using pieces of software where people can request an appointment or request a kind of call back, or when they're and that kind of thing, but they're closing these when those slots are maybe full, or if it's another kind of contact channel, if they're seeing a surge in inquiries coming through, they're closing that down, and indeed some of them they're closing down completely out with practice hours because they just can't manage the demand that's coming through that. Now, for all practices told us quite a wee bit about the kind of demand and the challenges and things like that, there is very much this view that going forward there needs to be that blended model because not one size fits all, but if there's going to be a change, now is the time to do it. Back over to you, Hannah.
Perfect, thanks Heather. And then on to our last deep dive, which is all around digital tools. So just flip to the first screen there.
Hi there, it's me. The tools that patients had used that they talked about in the research, they said they were not difficult because they were digital. But we heard quite in some detail how people had problems for other reasons. And it's perhaps important to say that this particular sample for qualitative research were recruited on the basis that we wanted to talk to them over a web call so that we could see them and ask them to hold up their mobile phone and show us what kind of apps they had, that sort of thing. So we're very conscious that not everybody uses digital services, and it's important to say there's another project that's looking at specifically at looking out for people who are not using digital services or can't afford to for the usual reasons. But what we heard from this particular group was that they didn't trust some of the digital tools they were using, because they couldn't get a really clear sense of how soon their request would be followed up. So, for example, somebody who had an urgent need to see a doctor and to get an on-the-day appointment was hearing from the same surgery in the same, what's the word? In the same task of booking the appointment, same appointment. She was hearing that the surgery would get back to her as soon as possible, within 72 hours. And then when the SMS text message came through, it said in due course. So she just kind of got unnerved by this. And I've spoken about this lady before, but she ended up going to A&E just because in the end, when she did speak to a GP, they said to do that anyway. So in subsequent situations, she's just gone straight to A&E and kind of saw that as simpler, more time consuming, but just kind of simpler than not feeling that she's kind of going around the houses from the phone to the website to being called back to being redirected somewhere else. Another thing was the issue of transparency. So as I mentioned earlier, just the sense that you might be disadvantaged by going through a particular channel. And given that this is the only one that online is the only channel where you don't actually speak to a person initially, that instinctively felt to people like they were less sure that they would get what they wanted. So people who'd called a GP, for example, expecting to talk to a receptionist, were being told to go to the website, use a booking tool, but that was catching them unawares because they hadn't received any communication from the surgery saying this was going to happen. So it came as a surprise, and they found themselves wondering how the whole thing was going to work, which is why some of them did three things in the end. You know, they call, use a website, call back again if they didn't get a reply quick enough, or go in person if they could. Several people assumed that the changes that they were seeing were purely due to COVID, and are still expecting things to go back to how they were when the pandemic kind of dies down to a point where it feels like the right time for that. So it's important that, in terms of learning from the experiments that these digital tools have allowed, that surgeries are aware that it's important to communicate to patients when the system is going to change. The other question that people were asking was who's looking at the messages and when. So some had concerns, for example, about going to a reception desk in person and having to say out loud what their reason was for visiting the surgery. So an online tool might be preferable for them, as I think we've mentioned before. Others were just feeling that much more removed at a time when they might be in greater need of talking to a person than they are for interacting with an online system. And some of the more digitally literate people we spoke to said they were surprised at how long it took them to request an appointment. One said she had to answer the same question 5 times. Another said the same kind of thing, that they couldn't anticipate what the dialogue was going to ask them for, so they would pack everything into one field and then end up repeating it. People forced to select options that they knew weren't correct either. So again, there's this thing about just knowing how many questions you're going to be asked and filling them out correctly was important to people. The tools were only available between certain hours, which is, as Heather's highlighted, GPs surgeries were having to do because their appointment systems were getting flooded in some cases, or the wrong people were getting through. And then the other issue about tools not being inclusive. So there are well-recognised international standards for building websites so that they can be used by people with access needs and people who need different formats, easy read for one. Some websites are very good at doing that, but it's not standard across the board. And of course, writing content so that anybody, lay people, can understand it. That's important too. Over to the next slide, please. So this is Adam again, I think.
No, this is me. Okay, so looking at it from or kind of what the practices have told us. So, and kind of first of all, some of the kind of digital solutions that have been brought in by practices are not being kind of viewed as kind of fit for purpose. Now, obviously, with the pandemic, things were kind of brought in extremely quickly, but there's this kind of idea there's no clear view of how they would be implemented or how they would actually work on the ground. And there was this kind of perception that those making the decisions about these digital solutions and these digital tools were people that are removed from that kind of on the ground experience. So they're not sitting in patient-facing roles, and so they don't have an understanding or a better understanding of how they might work on the ground, and that caused a little bit of a bit of friction. Also came through quite strongly about kind of these digital solutions that were brought in, although helpful in that it was given a different set of kind of citizens access that they maybe didn't access before. So people that maybe didn't want to use the phone and digital opened up, they started using it. But what that meant is that it wasn't digital wasn't reducing the calls coming through. It was just another channel and another set of people that were coming through on it. So it was like that increasing demand and increasing patient expectation. And what that did was it pushed that demand up to the front door of practices. But at the kind of practice level, there just wasn't the resource. There wasn't the resource there to support that. And that caused real issues, and that's part of this reason why services are switched on and off to kind of manage that. It was also kind of became quite apparent that that just who is looking at digital tools and whether they're working for both sets of groups, like how are they working for practices and how are they working for patients. We're speaking to practices and we're kind of asking about that, and it seemed a bit of a gap, and where practices are kind of speaking to people within their catchment and getting feedback and things like that is pretty patchy, and it's really dependent on the focus of the practice in general. So if you've got a practice who the kind of senior members or the decision makers are very much focused on like get feedback, how can we improve, what can we do, then that's going to improve things. But in others where their focus is elsewhere, it's not quite there. So GP practices might be saying, well, this seems to be working, and people are using it, so it must be working, but actually there's no really understanding of what that experience is like from the citizen side of things. So it's just that joined up approach that's not quite there at the moment. If we move on to the next slide. Also with the kind of new digital tools and whatnot that were rolled out, there was kind of this view that there's limited support and guidance on how to implement these. So like some described as like you're kind of given a link to a webinar or a YouTube video, and then you're kind of out on your own and how best to implement it. So there's this real sense of trial and error, which if you're a very busy practice and you're dealing with all this demand, like when do you find time for that? And it's a bigger risk of things not working, and like what do you do then? And that came through really strongly in this research. And some of that's coming from like that some of the digital tools don't integrate with the GP record system, which again causes this additional administration burden on top of everything else. And the fact that they don't integrate doesn't always become apparent until the practice actually starts using it. So this adds even more to that kind of frustration of trial and error and the worry about trying something new in case it doesn't work. And so one of the examples was like a practice who started using this digital solution or digital tool. Within a few, they realised that it didn't hook up with their GP systems, and it was just creating all this extra admin. And they used it for 6 weeks and then had to stop because it was just becoming unmanageable. And so it caused more work than what it actually solved. And that's a bit of a theme about a lot of the tools that have been used. And finally, a bit of a question about when things were brought in so quickly, practices didn't necessarily have the infrastructure to support those new digital tools. So they weren't necessarily, they weren't set up to use them for patients. They maybe don't have kind of like bandwidth issues, hardware issues, and it even came down to when you're looking at supported laptops and devices within the practices, getting those new pieces of software on itself can be a challenge, and it just takes time, and it's just an extra burden that practices are having to manage. So one of the recommendations that is going to come out of this is about solutions, and not bringing in solutions without finding out, like if it's tested with all groups, so you can see it from each side of the coin, and whether it's integrating with existing systems, because that's one of the key areas. You've got all these different systems and they don't talk to each other, and it just becomes very siloed, and it just creates the amount of administration work that's going on round about that. So that's me, and I think I'm handing back over to Adam now.
That's right. Thanks, Heather. So I'm just going to sum up a little bit. So it's important to say that we have a lot of empathy for practices who have been wrestling with what is a very complicated situation at the same time as trying to deal with a pandemic. The truth is that incorporating these tools effectively into a package of access channels that includes phone and face-to-face and potentially other things as well is very complicated, and many things need to be considered, and we've seen evidence of that. We need to know exactly what a tool is trying to do, what the problem is it's trying to solve. We need to understand more about how it will be understood and used and experienced by the people who are using it in the context of the other options that are available to them when contacting their surgery. We need to understand how citizens' needs are very diverse, and they have a variety of tasks they're trying to achieve, and how well will the tool meet those needs. And just basic things like any tool that doesn't integrate with a practice's IT system already is going to generate extra work straight off the bat, because there'll need to be manual data transfer taking place by a human being. And equally, if it doesn't integrate with the processes they have set up behind the scenes and how they manage demand as a team, then it's going to end up creating more work rather than solving problems. And lots of these are unintended consequences. And so we need to get better at predicting or spotting what these unintended consequences might be, so that we can work out how to mitigate them. And the truth is that practices are not IT experts, and they do not all have the time, knowledge, or support or experience to do this effectively every time. Next slide, please. But let's look at the positives. So many health boards, clusters and practices are experimenting with public-facing digital tools. And as we've seen, it hasn't always worked well for citizens or practices. But in every case, the reasons for that are very clear. There's no mystery about that. And so there's an opportunity. So during the pandemic, there was an enforced period of intense experimentation with these new methods. And we can now learn from that and build into a more rounded, cohesive and effective approach as we move ahead. So we believe that these digital tools are absolutely an important part of any strategies that are put in place to try and tackle access and demand challenges in primary care. And what's perhaps most heartening is that many across the conversations we had in practices and among stakeholder groups feel that now is probably the right time to intensify efforts in this space rather than backing away from it again. So I'm going to leave it there, and I'll pass back to Hannah.
Thanks very much, team. So just to touch on what will happen next then. So again, everything we've shown you today has been covered in a 12-week discovery. It's all great stuff, very informative, and there's loads more behind the scenes. So these are just three kind of ones that we've picked out to share with you today. But what are we going to do with all this information? So we're currently producing a report with a response to the issues that we've identified, some of which we've discussed today. And that will encapsulate our recommendations as a team, which you will be able to read through. So just going through some of the next steps on the slide then. So there'll be a presentation on Thursday back to project stakeholders. So that will be the in-depth, every kind of insight and finding that we've received. We'll discuss the recommendations, iterate if we need to, and then we'll produce the internal report the week after. So that's next week. And then we'll produce a public shareable report, so which you can all have access to, share as much as you want, really. So that will contain all the insights and the findings and recommendations, but we'll just remove those sensitivities around the interviews that we've done. And then I've touched on the last point there already. The recommendations will be discussed, and then the appropriate next steps as well, which will be discussed on Thursday. Great. Okay. So before we just go on to questions, and I know we're kind of running out of time, I would just like to finish to say a massive thank you for everyone attending today, for attending the previous show and tell, for being such an integral part of our project and hopefully the success of it as well. A massive thank you to the team for your incredibly hard work in such a short amount of time. And also the stakeholders as well. Anne-Marie isn't here with us today because she's off in Wales actually on holiday, but a massive shout out to her for all the help that she's put into the project. Some fantastic work, and we really can't wait to share the final report with you guys. Really exciting stuff. So I don't want to waste any more time. We've got hopefully around 8 minutes for questions. Feel free to put your hand up if you'd like to come off mute and kind of say your question, or you can put it in the chat box and I can pick that up that way. But we'll just pause for a couple of minutes while questions filter in. I can see some great stuff coming through in the chat already. It's quite hard to keep up with it while we're kind of presenting, but some really good conversations, specifically picking up around the greeting messages. One I don't think that Heather or Leonie has come up in the interviews, or Adam, so it's really good to kind of hear that perspective as well. Okay, we'll just give it a couple of minutes if there's any questions.
I think there was one from Jonathan from the Ambulance Trust. I don't know if we picked that up.
Go for it, Adam. I don't think I can see that, so if you've got it on your screen, unless Jonathan, you'd like to come off mute and ask it.
I can, yes. Can you hear me?
We can.
Can.
Yeah.
It was actually answered a little bit further down the chat and was in a report. It's really about the capture of what happens to those patients in the survey. Feel they can't get an appointment or don't get the response that they felt they needed. Where else do they go in the system? And I suspect I know some of the answer, but I'm really interested if the research captured how they went on that journey. Did they go to 111? Did they visit a UPCC? Did they go to an A&E? Where did they go, and what was their eventual outcome? And was that eventual outcome comparable to what the likely outcome would have been if they'd have seen the GP? Because I think it probably wasn't, but I don't know that.
In terms of what we captured, I can answer this. We won't have those findings from the survey because they didn't ask that question, but we did in our interviews with 14 participants ask them exactly that question. It's what did you do? How did you go about this? What did you do if that was taking too long, or you didn't get what you want, what you felt you needed? So that has been captured, but it's quite a long story to tell in a presentation like this. So we've kind of cut our cloth with what we're showing here. But I've got a note of your question, and it's something we will make sure to include in the report, because I think it's a good point.
Perfect. Thank you very much.
Welcome.
So just trying to get back off mute there. Thanks very much, Jonathan. Linda, you've got your hand up. Would you like to come off mute?
Yeah, sure. I did put a question up about whether there was any question about the resources that surgeries have got to actually deal with the new technologies and new digital equipment.
Heather, do you want to jump in here, or I'm happy to? Adam, I can see you've come off mute. If you want to take it, absolutely fine.
I think Heather's probably got more of the answer than I have on this one.
Oh, you're on mute, Heather.
Again, I don't want to use the word patchy, but it very much varies from practice to practice, like how much support is available to staff when it comes to training up in the new technologies and things like that. A lot of it is, like, particularly during the pandemic, where like it kind of sessions to like teach people how to use it and whatnot were very few and far between, and so a lot of it is like one person in the practice figuring out how to use it and then showing other people, and then a lot of on-the-job training as well. So yeah, really inconsistent across practices, I think, is the best way I could say it.
Is anything included in your recommendations about that?
Yeah, that is an area that
Oh,
we'll
good.
cover, yeah, round about kind of staff
Brilliant.
training, because it's something else that's spoken about quite a lot, obviously, about the lack of protected time and things for training over the last couple of years, and how that even that is like different from practice to practice, depending on what's in the contract and depending on the support of the kind of seniors within that practice, and what they're able to provide staff. But yeah, really different.
And it's a real core thing that we definitely bring out in our report and the recommendations, Linda, absolutely.
Is it something that could be included in the contract agreements?
With technology suppliers, that potentially
having a dedicated resource within the surgery, rather than it all being sort of done on an ad hoc basis.
Yeah, absolutely. So definitely stuff that will feed into our final report, Linda, when we kind of come to recommendations. Adam, I don't know if you want to add anything. I can see you've come off mute.
Yeah, I was just going to say that the contract reform side of things is really outside of our remit. But what we have noticed is a lack of consistency, which across the question you've noticed, but in other areas of training as well around care navigation and stuff, which would always be a cause for concern in a public sector service, which people have no choice to use.
Yeah.
Okay, great. Hopefully that's answered your question, Linda. I think we've got time.
Thank you.
Great. I think we've got time for one more, and I think Deborah, you've got your hand up, so that's perfect. If you'd like to come off mute.
Well, it wasn't actually a question. It was to say, as a practice manager, I could have answered the question, and I think you've summed it up quite well. I'm in North Wales. We've had no protected education for a couple of years. As the practice manager, invariably, we're the expert supposedly on everything in the practice. So we do the IT stuff, and we're having to constantly absorb stuff whilst trying to cope with the rest of our job. So I would say that fundamentally the admin team does need more support, but we've got 6 protected education sessions supposedly by the end of the year, and that's September, and there's nothing in place yet, so it's not boding well at the moment either.
Yeah, really appreciate you adding to that conversation. Oh, sorry, did someone else just come off mute there?
I was just going to say we feel your pain. I think, you know, you're speaking to a team that's worked on both large and small websites, and some huge ones over our combined years in this industry. And it's amazing how much effort goes into maintaining any kind of live service. It eats up resource, and it's complicated.
We've got the website that we had, we've got to completely rebuild that because the current providers, they're changing. And interestingly, going back to the Welsh language thing, we have to pay for 2 licenses because we're choosing to have an English version and a Welsh version. And I was told, well, that's your choice. You don't have to have a Welsh version.
Interesting.
I said, no, try that on Anglesey.
Indeed. Oh dear.
So, you know, there's things that are forcing change upon us in the practices that we don't always seek out, but it just adds to our workload.
Yeah, absolutely. Really appreciate you adding to that.
And Deborah, I hope you feel our findings have reflected that as well.
Oh, I've been very impressed by all the things you've been saying, actually, since I was a bit late joining, but yeah, you've captured it extremely well. Not sure what the answers are, but no, I'm very impressed.
Yeah, the difficult bit, right? Perfect. Well, I can't see, we're bang on 2 o'clock. I can't see any questions coming in. But if you do have any questions, my email address is on the screen. The chat box is still there after the session. So please do feel free to use that to put any comments, any feedback, greatly kind of appreciated. Just want to wrap up again by saying thank you so much for joining again today, being fantastic attendees and participating continually with the conversation. Really appreciate it. You've made the sessions really engaging. And we'll have the report with you, the internal one next week, with the public one, the shareable one, ready kind of soon after that. Perfect. Thank you very much, everyone.
Thank you all.
Thank you very much.
Thank you.